is the publication Obesity and Critical Care Nutrition: Current Practice Gaps and Directions for Future Research. Patients admitted to the intensive care unit, or ICU, increasingly present with obesity. This often requires individualized nutrition considerations due to underlying comorbidities, immunological factors, changes in energy expenditure, and other aspects of metabolism. Guidelines are available for the nutrition care of critically ill patients with obesity. These guidelines recommend an individualized nutrition approach, suggesting healthcare professionals consider that many factors can complicate the delivery of optimal nutritional care. Malnutrition screening and assessment is a key challenge in patients that are obese. A general clinical assessment should be performed to identify malnutrition in the ICU. Assessment in patients with obesity should also include biomarkers of metabolic syndrome, comorbidities, and inflammatory markers. Current screening and assessment tools are not all validated for patients with obesity. They may rely on imprecise measurements, such as body mass index. Malnutrition may be underrecognized and underdiagnosed in patients with obesity in the ICU. Assessment should also consider underlying malnutrition based on clinical reasoning, signs and symptoms of macro and micronutrient deficiencies, and poor muscle quality despite the presence of muscle mass. Patients should be monitored for refeeding syndrome over the course of treatment. We lack definitive research on how best to estimate energy needs for patients with obesity in critical care settings. In patients with obesity, energy intake should be guided by indirect calorimetry. If indirect calorimetry is not available, energy intake can be based on adjusted body weight and a published predictive equation or simple weight-based equation should be used. Predictive equations are easily calculated but were not developed specifically for populations with obesity. Predictive or weight-based equations should be only one aspect of nutrition assessment. Indirect calorimetry remains the preferred method to estimate energy needs among patients with obesity in the ICU. There is no consensus on protein requirements in patients with obesity, leaving clinicians to depend on limited evidence and current guidelines. Muscle mass loss may still occur in critically ill patients despite the delivery of what may be determined as adequate protein provision. Protein delivery should be guided by urinary nitrogen losses or lean body mass determination. If these methods are not available, protein intake can be 1.3 grams of protein per kilogram adjusted body weight per day, 2 grams of protein per kilogram actual body weight per day for patients with BMI of 30 to 50, and up to 2.5 grams per kilogram ideal body weight per day for patients with BMI of 50 or greater. Clinicians may be unaware of the risk of muscle mass loss in patients with obesity. Weight loss in critical illness may contribute to the loss of lean muscle mass rather than just fat mass. A 24-hour urine collection for nitrogen balance may not be practical or feasible. Protein needs may be higher in critically ill patients with obesity. An individualized approach is needed for nutritional and body composition assessments. Clinical status and nutritional needs should be reassessed frequently. Patients with obesity and critical illness present with several clinical challenges due to the possibility of underlying comorbidities, systemic inflammation, and a lack of evidence to routinely guide nutrition care. Nutritional strategies should focus on individualized care that considers the whole person, including the possibility of chronic stigma that could impact the delivery of effective care. Additional research should focus on the applicability of current guidelines and evidence for nutrition therapy in populations with obesity, especially in the setting